Alrighty, I think we'll go ahead and get going here. So hi everybody, good afternoon. Welcome to our COVID-19 update echo. This is something we're doing as part of our antibiotic stewardship echo, which regularly only happens once a month. But due to everything, we want to keep you all updated and be sharing, the latest information with you, be able to connect with you, support you with any cases that you're having. So today's session, we're going to hear from Dr. Mark Pandori, who's the Executive Director of the Nevada State Public Health Lab. He's going to give us some updates on testing and how testing's going here in the state. We're also going to take some time to go over our new case submission form that we created for any cases you may have. But real quickly, let's start off with some quick introductions, and then I'll turn it over to Dr. Levy to continue us on here. So I'm Troy Jorgensen. I'm the Program Manager for Project Echo Nevada, handle the day-to-day operations. If you have any questions about Echo, I'm the person to reach out to. And yeah, it's just so great to have you all joining us today. Thank you for being here. So Dr. Levy, you want to go ahead?
Just introduce myself for now. Mordechai Levy. I'm a UNR med geriatrician, but also medical director here at Project Echo. Happy to see so many kind of old faces that participate in all of our other echoes, and some new faces too, I believe. In some faces I think we haven't seen in a little while. So we're happy we could be here. This is something brand new that we're starting, and so just kind of be patient with us as we kind of figure everything out. And we're really looking for a lot of your all's feedback.
Please record your message. When you have finished recording, you may hang up or press 1 for more options.
As we figure all this out and get you the people in front of you that you need. So it's good to see everybody.
Thanks, Dr. Levy. And then Dr. Pandori, could you introduce yourself for us, please?
Hi, I'm Mark Pandori. I'm the director of the Nevada State Public Health Laboratory and an associate professor of pathology and lab medicine here at the University of Nevada School of Medicine. And thank you for the opportunity to talk about COVID-19 testing today.
Excellent. Great to have you, Dr. Pandori. And then Sneha, our other ECHO staff member.
Hi, I'm Sneha Sharma. I'm the program coordinator for Project Echo Nevada.
Thanks, Sneha. We'll move on here, Dr. Levy.
So this is our webpage. You can see here we have a COVID-19 case review form. So you just click on that, and this case review form pops up. There's kind of 5 sets of instructions where you essentially just identify the case or process that you want to present at the next echo clinic, and you'll get kind of feedback from the expert echo team. You'll want to describe brief aspects of your case, and this case form is completely HIPAA compliant through HIPAA compliant servers. So we ask you to avoid any personal health information, but if any is accidentally done, it is in a secure place. And then we would like the information kind of noon before the next clinic. So in this particular case, it would be Wednesday at noon for next week. And then generally, we want you to kind of summarize the case as best you can in about 5 minutes to give us about 20 minutes to talk about the specific case if it has to do with the patient. As you scroll down, with COVID, things are a little different. Lots of other things going on, such as policy or procedures or hospital or emergency care preparedness. And so if those are your issues, we just ask you to check the box. And then in the box below, just kind of state what your main concern is. Try and kind of keep it as brief as possible, as focused as possible, so we can make sure we give you the information that you need. And then any relevant background information. And these are kind of relatively small text boxes, but they'll expand to kind of fit as much information as you want. And then at the bottom, just kind of your role in the patient's care or your role in the hospital or clinic, and then whether or not you've kind of presented about this before, and then there's an extra box for comments. So try and make this as simple as possible, really only kind of 3 boxes, maybe 2 boxes where you have to kind of think and share the information about your problem. And again, this is right on our website, so we hope that you all use it. We'll be keeping an eye on it all week, and the sooner you guys can get us this case, the sooner we can contact the subject matter experts that we need to get their feedback. Because sometimes, as you know, we have to gather information, especially with something new like COVID-19. So kind of I know that was me talking a lot. I wanted to open up for questions about Project Echo or our case review form before we kind of open it up for specific questions about testing. Type in through the chat or just take yourself off mute.
Yeah, thanks, Dr. Levy. Yeah, any questions about that case form or the format of these sessions, how they're going to go? I did send the link out for that case form through the chat box. So if you want to save that, go ahead and grab that from there. And one other announcement I want to make is that AMA, PRA Category 1, and Nursing CME and CEU credit is available for this session today. Towards the end, I'll send the link out for that evaluation that you'll need to complete to claim that credit through the chat box. So question about point of care testing, and I think Dr. Grandori will touch on that.
Hi. Currently, there is no widely available point of care testing. There is a point of care test that was recently developed, which is a serology test. But I don't think it exists. It has been manufactured at a level at which it can be widely distributed yet. And with regard to serology tests as well, it's I think some caution needs to be exhibited with regard to how those are utilized, especially this early in our understanding of COVID-19. The serological rapid test that is coming would be false negative for people that are outside the window period or infected too recently, and then a positive result is not really going to evaluate whether or not someone is viremic, or it would really only be indicative of historical infection. So there are no point of care rapid tests that detect virion particles yet, but I'm sure they're coming pretty soon. The Gene Expert platform, which is not quite point of care, but is what we term a moderately complex test, which can be done in a clinic and by non-licensed individuals, rather medical professionals, just came online on Monday. And that is actually a PCR test, which takes approximately 30 minutes. It's available on the Gene Expert platform, which many of you may be familiar with. And that's about as close to point of care we have in terms of virus detection. I hope that answers the question.
Yeah, thank you, Dr. Grandori. So yeah, could you just give us a kind of a brief overview, summary of testing right now, and then we can get into some specific questions that I see coming in?
Sure, I'd be happy to do that, Troy. Here at the Nevada State Public Health Laboratory, we run the first assay that was made available for this. It's a PCR test, which was created at the CDC just weeks after the outbreak started. The test is a PCR test, which means it detects the genome of the SARS-CoV-2 virus. In fact, there's 2 PCRs for this test that's run at the state lab. And that means that it has to detect 2 very specific regions of the viral genome. So the specificity of the test so far out the gate and down the road as we are with it appears to be extremely high. The specimens that can be used for the test are NP swabs or combined NP and OP swabs. Yesterday on a call with CDC, we're hearing that nasal swabs are also going to be considered acceptable for this PCR test. And that's welcome because NP swabs are actually going in extremely short supply worldwide. Our particular PCR test came online on February 11th. That meant that we verified the test and worked out our ability to transmit results directly to the CDC on February 11th, and we've been offering it every day since then. It's important to note that a few weeks after that, testing availability, the ability to design tests was expanded and now includes many, many private partners. So while the test at the Nevada State Public Health Lab is the one I just described, there are several other PCRs, more than I can probably count now on both my hands, that are out there and are available and approved temporarily by the FDA under an EUA. Quest and LabCorp, which are large private testing organizations, offer PCR tests for COVID-19. So if you use Quest or LabCorp for your current testing, you can send specimens to them. If you're within the state of Nevada, you can send tests to the Nevada State Public Health Lab. It's my understanding that most of the other PCR tests that are run by private entities are single PCRs and not 2, but there's no reason necessarily to challenge their specificity in that regard. Here at the Public Health Lab, we have now used the CDC assay to test over 2,100 patients. Our bandwidth, or our rate of testing, is now up to 400 tests per day if necessary, although we tend to be getting about 150 a day right now. Initially, this test required confirmation at the CDC, which meant our positive results were presumptive and they had to be sent to the CDC to be confirmed. But about 3 weeks ago, that was removed. So any result generated at the Nevada State Public Health Lab is considered final and confirmed. Our turnaround time here, from the moment the specimen reaches the lab to the time that we generate a result, is 3.5 to 4 hours. If we get a specimen by 2, we've been turning those around in the same day, with the exception of 2 days where we were rather overwhelmed with over 200 specimens at once. But for the most part, if it doesn't get tested here by 2, we're turning them around on the next day. We do expect volume to go up, and I would have to recalibrate that perhaps if we do start approaching 300 and 400 a day. Lastly, I wanted to state that in terms of supply, the Nevada State Public Health Lab is supplied to run this test for several weeks. That is, we have enough to go into what we would call the foreseeable future. We did work with the Department of Population and Behavioral Health here in Nevada to establish our own system in Nevada to ascertain the quality of tests and test components. That means that the state of Nevada, labs within the state of Nevada, no longer have to go to FDA to seek approval for tests and test components. That can be done here within the state at the Department of Population and Behavioral Health. And given this flexibility, labs in Nevada, including our own, can now determine the quality of materials and tests, and that widens our ability to use different manufacturers. And as a result of that, I do not foresee supply problems here at the Nevada State Public Health Lab going forward. And I'm emphasizing that because I think if you see the media, you're hearing a lot about testing availability and there being not much. And while that's true in a broad sense, here in Nevada, we've worked very hard for the State Public Health Lab to maintain this capability, and we continue to offer it. Where there isn't a very large shortage is in with collection kits. And the term test kit and collection kit have been conflated of late. And here at the lab, we really like to separate those two things. The collection kit is the NP swab and the universal viral transport solution. Those are in extremely short supply. The FDA is allowing NP swabs to be put into sterile saline tubes. So I would encourage those of you that want to submit to go down that road. The FDA has an FAQ for diagnostics, and there they will provide you with a variety of options alternative to universal viral transport if you don't have them. Lastly, I'll say that in reference to this shortage, the Nevada State Public Health Lab is now manufacturing collection kits so that we can start to distribute them to partners here within Nevada that have a problem with shortages of collection kits. And we should have our first 1,000 done by the end of today. I hope that wasn't too much, Project Echo, but I am here now to answer questions.
Excellent. No, great information. Thank you so much, Dr. Pandori. So a couple of questions that have come in through the chat box. Please feel free to keep writing those in. That's what we'll be here for the next half hour to address your questions. So can you talk a little bit about sensitivity?
Yeah, so whenever we talk about these kinds of detection assays, there's two kinds of sensitivity that we have to talk about: clinical sensitivity and analytical sensitivity. This is a PCR test, and we tend to see in all PCR tests that are diagnostic extremely high analytical sensitivity. This test, like many other PCRs, is found to be capable of detecting down to around 10 to 50 virus particles, that is genomes. And so that translates to what we estimate is an extraordinarily high clinical sensitivity. Now, and we do see that with a lot of PCRs, but clinical sensitivity has not been formally defined for this test yet, just because we're so early in all of this and we're still collecting data. Number one, anecdotal evidence from all the public health labs in the country that are using the test are stating pretty high clinical sensitivity. However, here's where we have a hole in knowing in the sense clinical sensitivity. And here's a caution to everybody as well. Some papers have shown overseas that when PCR tests for COVID-19 are utilized on patients very early in their symptomology, there is the possibility of a false negative PCR test. We can't quantify that yet, but it looks like when people just become feverish and before their symptoms become quite more florid, there have been at least, well, I would say in one study, about 3 out of 30 cases where people were tested very early and it was found that they had a false negative, and it wasn't for 1 to 2 days after the fever started that they converted on the PCR test. Now this sounds scary, but it just means that we need people to be cognizant that a test on someone who's very early in their infection might be false negative, and we'd encourage people to get retested. This is not unusual in the field of infectious disease diagnostics. We've been messaging for hepatitis C and also for HIV that there are window periods to any test, whether it be a viral load test used diagnostically or an antibody test. We know that there are window periods, and we have to have regard for those from the clinical perspective. So to summarize, the sensitivity is extremely high. It probably approaches between 99 and 100%, but we have to be cognizant of testing too early. Thank you.
Thanks. Would you be able to speak at all about protocol for testing?
For what?
Protocol for testing?
Here, our protocol at the lab or for specimen collection?
Specimen collection.
Right now, the protocol is to, well, right now, formally at this minute, and it's going to change in the next couple of hours, I think, but an NP swab, it needs to be taken. I'm not a medical doctor. I would defer to Dr. Levy to instruct others how to take a proper NP swab. Now, because NP swabs can be difficult and uncomfortable and can induce coughing, and nasal swabs are going to come online shortly. I would say within a day or so, the procedures will allow that. But in terms of how to collect an NP swab, I defer to a medical doctor on the panel.
Fair enough. Yeah, thanks. So yeah, we are minus Dr. Krasner, our infectious disease specialist today. But yeah, for clinical related questions, he should be back next week. So these are going to be weekly sessions every Thursday, 12:15 to 1 p.m. So we hope to have him back next week and be able to address your clinical questions. So Dr. Pandori, do you feel that we're under testing in the state?
Well, so that's a difficult question to answer. I'm a public health laboratory director. So while I direct diagnostic medical testing, I come from the public health world where there's really two kinds of testing that are necessary in a situation like this. There's the medical testing that we need to help sick people get diagnosed so that we can treat them and, if necessary, isolate them. Looking at testing through the public health lens, there's the whole concept of surveillance testing, and that is just testing as many people who are at risk as possible and then ascertaining how much infection there is in the community. We're probably approaching, I feel in Nevada, enough medical testing, although I can't speak entirely to that. I can say our lab has testing capacity that is not being utilized. So it's either we're not being utilized properly or there's plenty of medical testing available. Where I think we're not accomplishing the proper goal is we're not opening testing up to asymptomatic at-risk individuals. So we just don't know what that quote-unquote denominator is in terms of infection. We don't know how much is really out there. We know from cruise ship epidemiology that many, I believe approximately 20% of infected individuals were asymptomatic. So we're failing in surveillance testing right now, but I think we're getting a C+, so to speak, in medical testing.
Got it. Okay, so Dr. Everts at Pershing General Hospital mentioned that they only have 35 kits there, and there's been a couple other questions about how to obtain the tests.
I think they're referring to the collection swabs.
I'm not sure. Dr. Wortgo, could I unmute you and you could specify for us?
Yeah, so my my question, because I'm with South Lyon, and we only had about, I think, 20 collection kits initially, and so we're really being limited into who we can test, basically reserving it for patients admitted to our small critical access hospital. And so getting those collection kits to be able to send for testing is kind of what my question refers to.
Yeah. So thank you for your service to the community there, and for your question. The entire world, my disclaimer at first, the entire world is short on these collection kits. So what we're doing here at the Public Health Lab, and I think we can support you, is we're starting to manufacture them so that we can provide them to clinics in Nevada. What I would ask you to do, I'm assuming 30 for you isn't going to last too long, right?
Not if we wanted to test the way that I think we do want to be able to test. Yeah.
Okay. What I would do, if you don't mind, is there a way, Troy, to provide my email address to everybody on the call?
Yeah, I'll send that out through the chat box.
If you send me an email, we can do what we can to get some swabs out to you. I think there's a courier that comes from you to us, Dr. Wartgau, but I don't know if it's bi-directional. What we can do is ship some out, I believe. We have to, even though we're constructing these here, we still have to ration them because there's an incredibly high demand, but I want to make sure that we give you some at least. If you email me.
I mean, right now our collection kits are basically coming from the Quad County resource. So that's Story County, Carson City, Douglas, and Lyon County. And I know, they get kits, they divvy them up. And like I said, I think the last I heard is we got 20 collection kits, and I think we're down to only about 3 left on those. And that's with strictly reserving them for, pretty sick folks that are inpatient. So
yeah, I'm sorry. Well, so I see what's going on here because we're giving Carson Health District swabs, and we're hoping that they distribute them. It would be ideal if we could continue that mechanism, but I don't want you to be without swabs. So if you could send me an email, what I can try to do here is what I will do here is set up a system where we can start to ship some out. It may not be all you want, but we'll do what we can.
Anything helps. Thank you so much.
Thank you, Doctor.
Outstanding. That's great. Thanks so much, Dr. Wartgau and Dr. Pandori. All right. So any other questions? I haven't seen any others coming through the chat box, but we're here for you. So yeah, any questions about testing, feel free to unmute yourselves with the little microphone icon on the Zoom toolbar. I don't know if anybody's joined by phone, but if you are, it will be *6 to unmute yourselves on telephone. So what will we need to use for collection kits once we go to nasal swabs and placing in saline?
Well, so if we go to nasal swabs, hopefully you have those. But what it does for the Nevada State Lab, since we're in the business now of manufacturing the kits, it'll open up for us the ability to buy nasal swabs and combine those with the viral transport systems. And that's easier for us to acquire than NP swabs at the time. The NP swabs have a subtlety to their construction to allow them to work properly. And those are basically out. The state got a few thousand from the federal government yesterday, or the day before yesterday. And we're using those to marry them with our universal viral transports that we're manufacturing here in the lab. I don't know how long that's going to last, because we certainly will be sending some to Vegas as well. But with the nasal swabs, what that'll do is it'll make it a little easier for us to construct kits. Some of our kits will be saline plus swabs, but we're transitioning to the full viral transport next week. I'm not sure I'm really answering their question, but it at least gave me an opportunity to explain to everybody where the nasal swab concept fits in with this shortage.
Okay. Do you think using saline for transport will decrease sensitivity?
Good question. So the CDC has completed a study. We heard about it on our call with CDC yesterday, and they saw within the parameters that are utilized, and that is within 72 hours cold, that's between 2 and 8 degrees, so that would be your specimen being in a refrigerator or an ice pack, or on ice or in a cooler. Under those conditions, there is no drop in sensitivity. Also, another option is to freeze them, and get them to us frozen. And actually, if it's beyond 72 hours, they do have to be frozen. Under those conditions, the CDC is seeing no appreciable sensitivity drop with the saline specimens.
Great, good question.
Yeah, it's a good question. It came up literally yesterday in our call with them.
Wonderful. Glad we're getting that most current information out here. Any other questions? Anything we can help you with today? Please unmute yourselves or write in through the chat.
So I was happy to hear that we still have some Mordechai Levy here. Happy to hear that we have increased capacity or more capacity for more testing, at least at the lab. If guidelines ever do change in the U.S. in the future, as far as who we're screening, how tough do you think it would be to increase that number above 400? Do you think that would be a big feat for the lab, or something that you guys could do relatively simply?
Yeah, the difficulty becomes dollars at that point, because the only way bandwidth can be increased is through equipment. We have the staff to do this, trained here. We do have online some orders to automate some of the process, but the bottleneck is now on some very expensive equipment downstream, which we call the PCR machine or the thermal cycler. How hard would it be? Well, you know, it's as easy as the dollars come in. I would say once we're up to 400, we might be able to push it to 500 specimens per day here at this lab. Going much beyond that would be something I wouldn't promise for 6 months. You know, the way that we're trying to deal with this is to get a coalition of labs to test. Public health labs, although they sound like big operations, and we do a huge variety of things here, we're not really built like Quest and LabCorp to handle an extremely high throughput. Public health labs sort of handle the beginnings of these things, and then the privates are supposed to come in and relieve that. But we're hearing even Quest and LabCorp are currently overwhelmed, and that their turnaround times are around 5 to 6 days. So I appreciate that we want to be able to broaden our testing capacity, but I don't see the equipment coming in here for at least 6 months to make huge breakthroughs in that regard.
Thank you.
Thank you.
Is there the possibility of getting PCR equipment from med school research labs?
It's come up quite often. Right now, the answer is no. For those of you out there that have worked in or understand diagnostic laboratory licensure, not only are the labs and the staff members licensed, but the laws or regulations rather associated with quality control require that the equipment be validated or verified for its purpose, and then that equipment be maintained on a regular basis. And in many cases, equipment that is used in research labs is actually labeled RUO, and the equipment that's sold to diagnostic labs would be IVD for diagnostics. So you might see two PCR machines from one company and think they're identical, but they're really not, because one's an IVD and one's an RUO. At the moment, we are authorized to use some research use only consumables. What we don't have the authorization to do is to use RUO equipment yet. The FDA has been very, very flexible so far, so that may change soon. And if it does, then PCR equipment from research labs may be usable. At this very moment, they aren't. Unless they happen to be IVD, but I don't think research labs would spend the money they need to have that label on their equipment. Thank you, though. The sentiment is appreciated.
Thank you for the question. Bart Anderson from Grover C. Dills Medical Center in Caliente shared, we are using Quest and our turnaround time is 5 to 8 days.
Okay, thanks for that information. We know they're pretty slammed. LabCorp is running a bit of a broader bandwidth operation, specifically here in Nevada, but they're also, I think, at around 5 to 6 days. So yeah, here at the Nevada State Lab, we are still, except on the days where we get over 250 specimens we're turning around, one within the day or the next day. I think once we get slammed really hard and we're up towards 300 or 400, I might have to start saying 1 to 2 days, but I honestly don't see greater than that, just because of how we've got this orchestrated from an industrial engineering perspective.
Excellent. Question here for non-clinicians, can you explain more about surveillance testing? Are you just checking for COVID? Wouldn't there be more false negatives, since surveillance testing might test people with no symptoms or light symptoms?
Sure, yeah. Well, that would be a possibility. Surveillance testing would be testing people on the basis of risk. This is a very common practice for gonorrhea, chlamydia, HIV, and public health. So if you reported to a public health clinic or an STD clinic, for example, and reported certain risk, it's possible that you would get a test, whether you were symptomatic or not, because we know for virtually all infectious diseases, there can be symptomatic and asymptomatic patients. Now, it's an astute point that you can get false negatives if somebody has a low, let's say, viral load, for example. But it's a risk that one takes whenever a diagnostic test is used, number one. Number two, and we think about this with HIV, viral load tends to correlate with public health threat. And and I guess with Hep C too, although Dr. Levy can speak to that, we know this very well with HIV. So when you do miss cases like that, you could at least make the argument you're missing the cases that have the lowest public health threat. But the goal of surveillance testing, as I was saying, isn't necessarily to get every single case, but to gather. I think the best way to look at it is there you're functioning as an intelligence agency, less as a medical agency, because you're trying to find out how much of this is out there, and then you're going to craft policies based on that intelligence. I hope that answers the question.
Okay, one more question that's come in. What role will Cepheid and BioFire platforms play?
Significant in a way. So first of all, Cepheid is, I alluded to it earlier, termed a moderate complex test, which means clinicians and medical clinicians can actually operate the test. Nurses and nurse practitioners and doctors can have it in the office and run it. So that may have some impact. It's the Gene Expert tends to be a low throughput. So you can have 2 modules, 4 modules. The largest I've seen have 64 modules, but those are extremely expensive. Most of them are about 4 modules, which means you can do about 4 tests, you can do 4 tests at a time. The turnaround on that, I'm hearing, is about 30, 35 minutes. So that would provide a quote unquote point of care or for COVID-19. The Gene Expert is just a COVID-19 PCR. BioFire is what we call a panel test. So the BioFire similarly has only a throughput of about 2 specimens every hour, or maybe if you have 2 machines, I think you get up to like 4 an hour. But the BioFire will detect 20 simultaneous respiratory agents, and they're tacking COVID-19 onto that. So the benefit of the BioFire is it takes a little longer. Well, the downfall is it takes a little longer and the throughput's lower, but the amount of medical intelligence that you get is much higher, because if they're negative for COVID-19, there's a chance that if they are symptomatic and that they're harboring another agent, the BioFire has a real capacity to tell you what that agent is. It includes viral and non-viral agents, and there are 19 or 20 of the most common. So that's the distinction there. They're both moderately complex and can be run at your clinic. But I'll add parenthetically, the Cepheid test is going to be around $60 per cartridge. The BioFire, you're looking at over $100 a test for materials.
Great information, Dr. Pandori. Thank you. So I saw a question come in from Dr. Bayan about co-infections with other viruses. We're going to hold those type of questions until we have Dr. Krasner back with us next week. But any other questions for Dr. Pandori on testing?
So, Dr. Pandori, this is Gerald with the Office of Rural Health, and I was just wondering, I know we've got a few providers and hospitals that we're not able to be on today. Is there anything that you could craft as far as doing that request for tests that you could send me that I could at least share with a few limited people that aren't online?
The collection kits?
Yeah, I'm sorry, the collection kits. Yes, the collection kits, I'm sorry.
Yeah, let's do that because this is going to be an acute issue. So if I craft something, Gerald, you could distribute that, or?
Well, I think Troy could distribute it to the folks online, and then I know there are a few others that I can distribute that to through like the Nevada Rural Hospital Partners and also the community health centers and the other clinics that are around, at least as far as rurally. So.
Yeah, I'll craft something like that today and get it over to you, Gerald.
And Troy, you could probably put that on the website too, but also email that out, couldn't you?
Yeah, and we can announce it at these sessions each week too.
Yeah. All righty, we'll thank you.
Thanks, Gerald. Question, can you comment on IgM versus IgG testing for reinfections?
Right now, I'm not aware of the performance characteristics of any serology test for COVID-19. I would be willing to speak only in general terms about IgM versus IgG based on what we've seen for other viral infections, but I'm not so sure that would meet the demand of the person asking the question unless they want that.
Yeah, no, let's hold off on that then. All right, anything else we can answer or help you with today? We've got a few minutes left here.
Oh God, this is I can't talk. Never mind. I'm a little laryngitis here. I'm trying to type something in.
Yeah, go ahead and write that through the chat then. That's fine. Anything else? Everybody feel free to unmute yourselves, a little microphone icon, or you can hit Alt-A on your keyboard or use that chat function. We've got a couple minutes left here. So while we're waiting for that question to come in, I will send out the information for you to claim CME or CEU credit for this session today, and then pull up our website here real quick to show you the upcoming schedule. So like I said, this is going to be a weekly session where we're going to be giving you, you know, the latest and greatest in COVID-19. So we hope to have Dr. Krasner, our infectious disease specialist, back next week. But this was a great session today with Dr. Pandori. Discussing the testing. So yeah, every Thursday, April 2nd, April 9th, and April 16th is our current list of dates. So we hope you'll join us for those coming up, and then keep an eye out for that link for the CME evaluation coming through the chat here in just a second. I haven't seen that question come in yet.
Yeah, and Mordechai Levy here, Medical Director. And as questions come up over the week, we really want to encourage you all to use that case review form. Again, fill it out so we can get ahead of a good idea. Some questions may be administrative or clinical, and so we want to make sure we have the right people because Dr. Krasner may not be able to answer all those questions. And we do have lots of experts and lots of different things with COVID here at the university, and so we'll do our best to get who we need on camera next Thursday. But the only way to do that is to know what you all need and what you all want.
Thanks, Dr. Levy. So if you think a patient was tested too early and their first test was negative, do you recommend a time frame for retesting, or do you retest based on worsening symptoms?
Well, very, very limited data. The publication that I saw out of Singapore where a fairly rigorous attempt was done on this, it was that if you wait the longest it took was 3 days, the third day after that first one. So you test, you get a negative, let a day go by, they were positive on the third day. And that was the worst case scenario. So it's really very difficult to base on an N of 1 like that, but that's at least what we've got.
Okay. How stingy to be with test kits? We've been holding off on testing unless high risk. Should we be testing more, for example, patients who have fever, cough, but no known exposure?
Yeah, I wish I really could answer that question. It's I would ask that they defer that to their health district, either the state or if you're in a health district to them, because they're really modulating that and just making those decisions. Here at the lab, if we've got the capacity, we'll test anything that comes here. We're not turning anything away. So we're not getting a specimen and ascertaining whether it meets criteria or not. We're just testing it.
Thanks. I realize I sent the wrong link for CME, so sorry about that. I'll resend that through the chat right now. We've got just another minute left here. Anything else we can help you with? Comment here from Steve. At our facility, we are only testing for patients being admitted or healthcare workers. Alrighty, I think we'll wrap up for the day. It's just about the top of the hour here. Thank you so much, everybody. This was great. I'm glad we're able to answer your questions and support you with this. So we'll be here again next week. Like I said, this is a weekly thing. Thursdays at 12:15. Same Zoom link and code that you used to join today. So we hope you'll join us then. In the meantime, please check out our website, submit a case if you have one, and we look forward to seeing you again. Thanks so much, everybody. Take care.
Take care.